I'm a professor of medicine at Mayo Clinic, Arizona, and I focus on multiple myeloma from a clinical and research standpoint. And I'm also associate director of the BMT program and section head for the myeloma at Mayo Clinic in Arizona. In terms of safety, there were no new safety signals observed with the use of Etentamig compared to the previous studies of Etentamig, the first in human phase 1 and arm A of the phase 1B. This arm B did not have any step-up dosing, and there was no patient who received prophylactic tocilizumab. So with that in mind, the CRS rate was 57%, and there were no grade 3 and higher events seen. Most of the patients had grade 1 CRS, so that was in line with what we expected. In terms of ICANS, only one patient had a low grade 1 or 2 ICANS. There were no high grade events seen. And of course, there were infections seen in this trial with a follow-up of 14.3 months. The longer the follow-up, we think the risk of infection, the cumulative incidence of infection seems to be higher. And there is interesting data available in the form of IVIG. I think altogether, 55% patients received IVIG. So majority of patients received IVIG as a primary prophylaxis. They did not wait for the IgG level to drop below a certain threshold before they started IVIG, whereas a small group of patients also received IVIG preemptively, meaning once the IgG level dropped to less than 400. So the IVIG utilization was not mandated by the protocol, so it was left to the investigators and the institutional guidelines. Having said that, there were 2 patients who died as a result of infections, and both of them did not have IVIG at the time of event. One patient had sepsis, the other patient had pneumonia. So the patient who had sepsis and died from it did not have IVIG previously, and the patient who had pneumonia did receive IVIG, but about a week after the onset of the adverse event. And only one patient discontinued treatment due to an infection. Arm C evaluated Etentamig in the outpatient setting, and the emphasis was on defining the optimal Etentamig dosing schedule or initiation schedule. So based on the results from Arm A, where the step-up dose was implemented, there was the same step-up dose of 2 milligrams given on cycle 1, day 1, followed by full dose of 60 milligrams on day 4, which was then continued subsequently every 4 weeks. And in addition to that, while prophylactic tocilizumab was not mandated per protocol, if the investigators wish to use tocilizumab for prophylaxis, or if the institutional guidelines recommended it, the Arm C allowed that. And so the data showed that overall, the incidence of CRS was, I think, down to 27% in the overall cohort of 60 patients in Arm C. And that included all patients, including patients who received prophylactic tocilizumab, and there were 16 patients. And when we looked at the data from only those 16 patients who received prophylactic tocilizumab, none of those patients developed CRS. So I think that was an eye-opener because it felt like these patients received only one dose of tocilizumab before the step-up dose, and so the combination of prophylactic tocilizumab and the step-up dose led to none of the patients having CRS, which could be the key to overcoming the barrier to the delivery of Etentamig in the outpatient setting, and among community practices where there is the emphasis is on efficiency, and the resources are limited. Time is limited, personnel are limited, and so this could be the key. This could be critical change to the dosing schedule that would allow community to start using bispecific antibodies without having to admit patients for monitoring, without worrying about patients coming in the middle of night with CRS, and having to depend on their hospitalists who may not be as worse with the CRS management, and the community oncologists may not have to worry that things will fall through the cracks, and patients will end up in a worse shape because of CRS. So, in the end, all these arms are small cohorts, and I do think that Etentamig has significant potential based on the efficacy as well as based on the safety. It's conveniently dosed every 4 weeks, and even among patients who do end up developing CRS, most patients would need only one dose of tocilizumab to manage the CRS in the outpatient setting. We saw from Arm C half the patients could be managed outpatient, but I think we need to wait for further data coming out of the phase 3 registration trial, Cervino, and I think that trial also allows prophylactic tocilizumab if so desired by the investigator. So I think we will need to wait for the drug to be officially evaluated in a phase 3 registration study and approved and marketed before we can talk about preferentially using Etentamig as the BCMA bispecific. Up until then, it's really useful data, and I hope the phase 3 data shows similar results, similar promise, so that we can one day start using BCMA bispecific in the form of Etentamig for our patients in the community, and majority of patients are in the community.